Hi, everyone. My name is Dr. Kelly Ruef. I'm a clinical consultant here for Precision Analytical. I used to be Dr. Kelly Head, but I got married in June. So now I'm Dr. Kelly Ruef. If you find me on Instagram or Facebook, it's still under Dr. Kelly Head, but that will likely change to Dr. Kelly Ruef in the future. So today, thank you for taking some time out of your day for our August Facebook Dutch case study. Today, we're talking about infertility, irregular cycles, and elevated estrogen. So, mainly going to be talking about how hormones, especially elevated estrogen, can be involved with infertility. So, I'm excited. I'm excited to talk about this one. All right. So, this is me, and there's my Instagram. So, but again, it'll likely change to Dr. Kelly Ruef, Ruef, in the future. So, let's just jump right into it. So, this is Allison. Of course, not her real name, but I like to call her Allison. I feel like she looks like an Allison. And even though she's smiling in this picture, she really is having a lot of struggles with infertility, with PMS every month, with some fatigue, some difficulty with sleep, some stress, some anxiety in her life, and some mild depression. She's in her mid 30s, of course, looking to get pregnant. And her BMI, I always think it's interesting with fertility to calculate BMI. Because if someone's BMI is too low or too high, it can have some negative implications for fertility. So her BMI, she's at 19.5, and what we consider normal is 18.5 to 24.9. I know BMI is not like the best marker out there, but it can give us a little bit of data or information about weight and maybe body fat percentage. So to some degree. So her BMI, it's a little on the low side, and it's possible that gaining some fat tissue could help with her fertility issues. It might not be successful, it might not be the issue here, but it's something that I keep in mind. So she's got these irregular cycles, and she tends to have longer cycles. So you can see her last 4 cycles were 41 days, 33 days, 34 days, 41 days. So a normal cycle length is anywhere from 21 to 35 days. So when she's having these like 41-day cycles, that's definitely getting on the longer side. So she's not taking any pharmaceutical medications. Her supplements, of course, she's taking a prenatal, fish oil, vitamin D, magnesium, and cortisol calm by pure encapsulation. So I wrote down the ingredients. Looks like some ashwagandha, some rhodiola, so some adaptogenic products, magnolia extract, L-theanine. Those are going to be a little more calming. So I'm assuming she's taking this for her anxiety and her stress. So a little bit about the prenatal vitamin, first of all. Of course, when patients come to me with supplements, I always want to make sure they're from a good brand, they're in the right forms. I want to make sure they're actually taking the supplements. But with the prenatal vitamin, it's usually best to supplement with a prenatal vitamin at least 3 months prior to conceiving. And especially if coming off an oral contraceptive pill, we know that OCPs can deplete nutrients, including folate. So here's a research study, and you can see where I highlighted it in yellow. So it's been shown that it depletes folate, B vitamins, vitamin C, vitamin E, magnesium, selenium, zinc. So we definitely want to try to take a prenatal after we come off the OCP just to help replenish those nutrients that were likely lost. And especially folate. We all know that folate helps to prevent neural tube defects like spina bifida and encephaly in babies. But here's some fun. I just thought this was like some fun knowledge about folate. It wasn't actually discovered until 1941 when scientists isolated it from spinach. And there were actually these research scientists in New York who called themselves the folic acid boys. And they were the first ones to actually synthesize folic acid in the 1940s. If you want to just talk about folate in general, or folate is the general term for vitamin B9. Folic acid is the synthetic form. And then the active forms, those are going to be L-methylfolate, 5-MTHF, folinic acid, so not folic acid, but folinic acid, and metafolin. So those are the forms that I look for in a prenatal. Of course, folate, it's one of the 13 essential vitamins. So our bodies cannot make it. We have to supplement with it. And there was one study that showed that only 25% of women are supplementing with folate before getting pregnant. So, of course, I'd personally like to see that percentage a little higher, just because folate is so important for fetal development. And these women, interestingly, the women who were supplementing with folate prior to getting pregnant were less likely to have small for gestational age babies. So, of course, folate helps to prevent those neural tube defects. But low folate in pregnant women has also been associated with anemia and peripheral neuropathy. So, another reason to make sure we're getting enough folate. So, with the prenatal vitamin, I always ask, is it from a trusted brand? Is it a good quality? Does it have the active form of folate in it? We don't want the synthetic folic acid. We do want the active form, and we want at least 400 milligrams of folate. A lot of people will aim more towards 800 to 1500 milligrams a day of folate. And you might want to aim on the higher side if someone has an MTHFR defect or issue or mutation. Remember, with the MTHFR issue, they're just less able to produce folate on your own. The active form of folate, I should say. One other thing I just kind of threw in here is B12. I always like to make sure that the form of B12 in the prenatal is more in the active form, so maybe like a methylcobalamin instead of a cyanocobalamin. And I try to make sure that there are sufficient amounts of B12 in the folate, so between 150 to 1,000 micrograms. B12, we know it's important for fertility. It can improve pregnancy outcomes and lower rates of miscarriage. Kind of like vitamin D. If you're low in vitamin D going into pregnancy, you're more likely to miscarry. And it might have something to do with vitamin D's ability to regulate the immune system. And remember, when we get pregnant, we have the implantation of the egg in the uterus. There's a lot of immune activity going on there. Okay, so other questions about her supplements. What form of magnesium is she taking? Magnesium citrate can be helpful for constipation. Magnesium glycinate might be absorbed better. Is she taking a vitamin D2 or a D3? Usually D3 is the better form, and a lot of people pair it with K2. Is she taking a fish oil? I usually like to use like a liquid fish oil instead of a capsule fish oil, if they can tolerate it. Because with the liquid fish oil, when you're tasting it every day, you can tell if it's gone rancid. Whereas in a capsule form, you don't always know when it's gone rancid. And once it's gone rancid, it's going to be more pro-inflammatory. It's not going to really work in our favor. And of course, I'm going to ask, how many capsules of cortisol calm is she taking? I want to know the dose of the herbs, the dose of the L-theanine. All right, so this is her Dutch cycle mapping. And this is page 1 of the report. You can see that there are 2 graphs. Estrogen's on the top, progesterone is on the bottom. And we're looking at her estrogen and her progesterone levels during the course of 1 cycle, which is pretty cool. This is page 2 of the cycle mapping. And I like to show page 2 because it does show us the serum equivalent estimate. So it's kind of what we estimate is going on in the serum, with estradiol on the top graph and progesterone on the bottom graph. And if you look at the very bottom, see that box of data? You can see the progesterone serum equivalents throughout the cycle, throughout the month. And you'll notice around cycle day 33, or measurement number 8 in that little box, that her progesterone is at 15.1, which is pretty decent for fertility. I like to see it around 15 or 20 when it comes to fertility. So this is kind of like a zoomed in look at page 1 at the 2 graphs. And remember, we've got the estrogens on the top, the progesterone metabolites on the bottom. You'll notice there's this kind of like black dotted lines. Those are the upper and lower reference ranges for estradiol on the top graph and progesterone on the bottom graph. Just keep in mind this reference range is for a 28-day cycle, and her cycle that she tested was 41 or 42 days. So that's why her graph extends beyond the black dotted lines. It's because her cycle length was longer than 28 days. And that's kind of why her whole graph is shifted to the right, because she's ovulating later on in her cycle. So I also zoomed in to the box of data that's on the bottom of page 1. I think it's important to look at all this data when you're interpreting a cycle map. And you'll see the very top row is the measurement number. We always have 9 data points on the graph for the cycle mapping. Below that, you'll see the day of the cycle that each point corresponds to. And then below that, we have all the data. So we look at estradiol, estrone, the 2 progesterone metabolites, and also the progesterone to estrogen ratio. And then if you keep looking at the very bottom of page 1, you'll see all of the different reference ranges for the different phases of the cycle. All right, so let's look at her estrogen levels. So here we can see that she's having her ovulatory estrogen surge around cycle day 26. And we can see her estradiol is 15.1, so I highlighted it. And the normal ovulatory range for estradiol is 4 to 12. So her estradiol during ovulation is getting above range. It's high. And the same with her luteal estrogen. You know, if you compare the numbers down in the box on the bottom, so cycle day 30, her estradiol is at 7.6, 33 at 6.4, and cycle day 36, she's at 5. And the luteal estradiol reference range is 1.8 to 4.5. So her estradiol in the luteal phase is above range. So she's just got some high estrogen. What about her progesterone? So I showed this a little bit earlier, but you'll notice that when her progesterone is peaking, looks like it's around cycle day 33, her serum equivalent estimate is about 15, which in my opinion is pretty decent for fertility. I want it between 15 and 20. So I think her corpus luteum is making enough progesterone. What about her progesterone to estrogen ratio? So we do look at that. You can see in the highlighted towards the bottom of the box, her ratios on cycle day 30 is 77. On day 33, it's 131. In cycle day 36, it's 128. And our range, what we like to see is between 100 and 500. I honestly like to see it closer to the upper end of that reference range, around 400 or 500. So hers is low, and it's not because she has low progesterone. It's because she's got estrogen excess. So all that estrogen is bringing down her progesterone to estrogen ratio. So another thing I like to look at with fertility is the luteal phase length. And a typical luteal phase length is from cycle day 16, or sorry, it's 10 to 16 days in length. But I think for fertility purposes, it can be helpful for that luteal phase to be at least 12 days, like 12 to 16 days in length. And that's because it takes about 7 days for that egg, once it's ovulated, to travel to the uterus. And then it's interesting, but the egg will kind of float around in the uterus for about 1 or 2 days and before it implants. And then the uterus, like the cell signaling in the uterus, if there's not implantation, about 4 days before you get your period, you'll start having cell signaling to break down that uterine lining for menses. So if you have 7 days for the egg to travel, at least 1 day for the egg to float around in the uterus and implant, and then 4 days for that, before the cell signaling starts, when you add it up, it's about 12 days. So we want the luteal phase to be about, 12 to 16 days. So usually ovulation will occur within 24 hours after that ovulatory estrogen surge. And to calculate the luteal phase length, it's helpful to know when she ovulated and how long her cycle was, right? Because that luteal phase begins once the egg is ovulated and it ends with the start of the menses. So let's try to figure out when she ovulated. So on the bottom of the cycle mapping on page 1, there's a sentence that says measurements are made from individual samples and or 2-day sample averages to give an optimized overview of the hormone patterns. So I always encourage practitioners, always look at the requisition form. It includes the collection card. And we can see where the lab got the data because the lab will write in a red pen, where they got that data. So for example, when it says day 26 on the cycle mapping, it's actually an average of day 26 and 28 data. So remember we said she had her ovulatory estrogen surge on cycle day 26. So that was an average of day 26 and 28 data. So we know that her ovulatory estrogen surge likely occurred on days 26 or 27 or 28. And because usually ovulation occurs within 24 hours, she probably ovulated around cycle day 27, 28, or 29. And we know she had a 41-day cycle. So that would mean her luteal phase length is likely between 13 to 15 days. So her luteal phase length looks good when it comes to fertility. What if you did have someone whose luteal phase was short? Let's say it was 10 days or 9 days. I tend to look at stress in their life, prolactin levels in the serum, but there is some research showing that Vitex can help normalize short luteal phases in women, especially if they're really like stressed out and their prolactin is kind of transiently increasing a little bit. So, you can consider Vitex. So there's some other helpful tools to calculate that luteal phase length. And it's basically tools to help understand when a woman is ovulating. So one is basal body temperature. And another one is an ovulation predictor kit with those urine LH strips. So remember, we get that estrogen surge, which causes LH to surge, which causes ovulation. So these are some other ways to know when you're ovulating in order to calculate your luteal phase length. And I just wanted to say that, the basal body temperature, the ovulation predictor kits, they'll kind of let you know when you're ovulating or when the patient is ovulating, but it might not be helpful to time intercourse like during that cycle that you're measuring them, because by the time you find out you're ovulating, you usually have maybe 24 hours for intercourse to get pregnant. Sometimes you just miss the window. Like by the time it comes up positive on the LH urine strips, sometimes you've just kind of missed your window for that month. So our fertile window is like the 5 to 6 days prior to ovulation and about 24 hours after ovulation. All right, so this is a summary of her results. She has estrogen excess. She's got a low progesterone to estrogen ratio because of that estrogen excess. She's got this long cycle length, but she does have normal progesterone and a normal luteal phase length. So that's really good. She's got that going for her. All right, so when it comes to estrogen excess and fertility, before I go into the research, I first want to say that I've seen women with estrogen excess get pregnant. So it's not like if you have estrogen excess, you're infertile. It's not true. You can still get pregnant, but for some women, helping to lower that estrogen or balance the estrogen progesterone ratio can improve fertility and can improve that pregnancy success rate. Because it really is this delicate balance between estrogen and progesterone helping to prime that uterus for implantation. So this is one study where they showed that elevated estrogen levels can shorten the implantation window. So it shortens the amount of time that the egg has to implant within the endometrium, within the uterus. Just keep in mind, this study was done on mice. It wasn't on people. But you'll notice here with this research, you can read it. I highlighted some of the more important parts of it. But the uterus in these mice became refractory at higher doses of estrogen. and didn't support implantation after a second exposure to estrogen at either a low or high dose. So it just makes that endometrium less receptive to the egg. And you can see with this chart here on the very top, it's all red and it says refractory. It just means that the uterus wasn't accepting the implantation of the egg. And you can see that with higher estrogen levels. This is a different research study. This was actually done on women, on humans, and it was on women with endometriosis. And it was interesting because they shown that progesterone resistance and estrogen dominance can decrease endometrial receptivity to embryo implantation. So kind of like a similar message here. I really like this first sentence. I think that they kind of wrote it really well. It says, in the healthy endometrium, so in a healthy uterus, progesterone and estrogen signaling coordinate in a tightly regulated dynamic interplay to drive a normal menstrual cycle and promote an embryo receptive state to allow implantation during the window of receptivity. So it's really talking about how we do have to have this interplay between progesterone and estrogen in order to prime that uterus for implantation. So it might be helpful to work on lowering her estrogen levels. Of course, we need to know what contributes to high estrogen first. So these are some things that contribute to higher estrogen. If you're overweight, you can have higher estrogen. In perimenopause, we tend to see women on this estrogen roller coaster. Blood sugar issues, PCOS, thyroid issues, increased aromatase activity. Remember, aromatase converts androgens to estrogen. So if you have more aromatase activity, you'll tend to have more estrogen. Endocrine disruptors. So think about BPA, plastics, look at the shampoo, the household cleaners, are they burning cheap candles, that type of stuff. Also, alcohol consumption can elevate estrogen. If you're not able to clear the estrogen out of the liver or in the stool via the gut, then you can have higher estrogen. You can always do a stool test and test for beta-glucuronidase. If beta-glucuronidase is elevated, it's usually a sign of dysbiosis. But what happens is if beta-glucuronidase is elevated, it can actually cause estrogens that are in the stool, ready for excretion. It can cause those estrogens to be reabsorbed back into the body, recirculated back into the body. So in those cases, treating the gut can be helpful. Calcium D-glucarate can be helpful. And of course, estrogen supplementation, if you actually take DHEA and testosterone, that can elevate estrogen. And then low sex hormone binding globulin. If you have less binding globulin to bind up estrogen, you'll see more of it in the free form, in the active form. High inflammation, stress, high androgens, ovarian cysts, these can also contribute to estrogen. So, we know that stress and high androgens can contribute to estrogen. So let's check out her Dutch Complete. So she also paired this with the Dutch Complete, luckily, so we can see her androgen levels. And these are her androgens. I circled them here. We've got testosterone and DHEAS, which a lot of people are familiar with. But we also have the etiocalanolone and the androsterone, which are these downstream androgen metabolites. So it just gives us an additional information about her androgens. And for her age range, her androgens are looking good. They're within range. And even her androgens on page 2. So we have a few androgens on page 2 that are not on page 3. So I like to point them out, and they're here on the bottom of the screen. They look pretty good too. Her 5-beta androstenediol is a little on the high side, but any metabolite that's a beta metabolite is going to be less potent, less androgenic. And this one, it's more downstream. It's not a very potent androgen. So I'm not concerned that it's slightly above range. I think overall her androgens look really good. And if we look at her adrenal panel, she's actually got low cortisol, kind of normal low output of cortisol. So that metabolized cortisol is normal low. Sometimes that can give you an idea of overall cortisol output. And then her cortisol in circulation is also normal low. The good news is she has that diurnal pattern throughout the day. That's really good. It's not flatlined, but her output's a little on the low side. So when I see lower cortisol, I start to wonder about chronic stress in her life, because usually in the early phases of stress, we have high cortisol when we're trying to run away from the bear. But over time, all that high cortisol has a negative feedback on the brain, and it ends up telling the brain to lower cortisol. Because having high cortisol for too long, it's not good for the body. We tend to gain weight. We tend to have poor regulation of blood sugars and inflammation. We tend to have poor wound healing. So we don't want to have high cortisol for too long. So chronic stress, you tend to see low cortisol. So yeah, I'm going to check in on that anxiety and that stress, because that could really be playing into her elevated estrogen, maybe her fertility issues. So what do I think is contributing to her estrogen? It could be a number of things. We've got a lot more workup to do. I'm definitely going to look into the stress and the anxiety and the inflammation, but I'm also going to look into these other things that I have listed here. So I'm going to check her blood sugar out in the serum, her thyroid out. She might have increased aromatase activity. You usually see that like stress and inflammation can upregulate aromatase. So can obesity and blood sugar issues. We know she's not obese, so that's not contributing to it. Endocrine disruptors, like I said before, I'm going to look at her shampoo and the plastics in her life. And, poor liver gut clearance. Maybe she's not clearing out that estrogen effectively. So we'll look into that. And maybe low sex hormone binding globulin. So a lot of times you'll see that things that contribute to high estrogen can also contribute to irregular cycles. So I just wanted to add this in so that you can see the comparison. Stress, low body weight, under eating, over exercising. A number of these things could be contributing to some of her irregular cycles also. And here's a list of a few other things that contribute to irregular cycles. So premature ovarian insufficiency. If the ovaries aren't producing the sex hormones, then we can have some issues with irregular cycles. But I think her ovaries are working okay. She's actually making too much estrogen. All right, so this is the further workup that I would like to do. Some of these labs are really basic, like the CMP and the CBC. But I want to look at her blood sugars, her sex hormone binding globulin, her thyroid, her inflammatory markers, the CRP and the SED. And then vitamin D. Remember I mentioned low vitamin D is associated with miscarriage. Here's some additional workup that you can consider. I mean, you could always look into the ovarian reserve with patients with infertility. You can do an HSG just to make sure that the fallopian tubes are open and working correctly. Sometimes women have issues with fertility or infertility if they have autoimmune issues. So sometimes people will look at these autoimmune antibodies. And of course, we can look at the beta glucuronidase in a stool test. Remember, if beta glucuronidase is elevated, it could cause estrogens in the stool to be reabsorbed back into the body instead of being eliminated. So it can elevate estrogen levels. We can look at micronutrient testing just to evaluate her nutrient status. And then further work up with possible endocrine disruptors. So you can look at a lot of these in the urine, like pesticides, different chemicals, glyphosate or Roundup, mycotoxins, heavy metals. All of these can affect fertility in some women. So these are all like things that I might look into further down the line. So with treatment considerations, this is a summary of her symptoms. Remember, she's got some of that PMS, some fatigue and stress and depression. These are the supplements she's already taking, remember? And with PMS, I wanted to just share what the research shows. I think this is really interesting. So research has shown that magnesium and B6 can help with PMS symptoms, but also zinc and antioxidants and avoidance of hydrogenated oils can help with PMS. And then lowering inflammation in general can help with PMS. And I feel like a lot of these things too, just overall general support can help with fertility too. Also, Vitex has been shown to help with PMS. This was more premenstrual dysphoric disorder that Vitex was helping. And then, of course, lowering stress is going to help with PMS. So far, her treatment plan, I would probably switch her to a prenatal that has the proper forms and doses of the B vitamins and have one that has enough D3 and K2 in it also. Might switch to a magnesium glycinate powder, so a magnesium that she can absorb well. And of course, the fish oil, switch it to a liquid, good quality. I want to make sure it's not rancid. It's not going to create more inflammation in her body. And then the cortisol calm, the pure encapsulations, I might increase that dose to 2 capsules twice a day, which might just help with that stress and that anxiety picture a little bit more. Remember, the stress and anxiety might be elevating her estrogen. So if we can kind of tone that down, estrogen levels might normalize, and the cycle length might normalize too. Of course, I want to avoid the hydrogenated oils, get good sources of omega-3s in the diet, adequate protein to balance her blood sugars. And a lot of these are going to lower inflammation in the body. Remember, high inflammation can lead to higher estrogen. So when I do a lot of these anti-inflammatory approaches, I'm working to lower inflammation and to lower estrogen levels. Plus, when we're lowering inflammation, when we're regulating the blood sugar, it tends to improve our sleep. It tends to improve our PMS and our mood. Choline and TMG-rich foods. So choline can help improve fertility. It also has been shown to prevent neural tube defects, just like folate. So any woman who's looking to get pregnant, I usually have them take choline prior to getting pregnant. Keep taking choline during the entire pregnancy because it's going to help avoid those neural tube defects, but also help baby's brain development. And even continue choline during breastfeeding. I think choline is just super important when it comes to fertility. And of course, turmeric. So maybe getting like a golden milk to drink every day. Maybe adding more turmeric to curries when she's making rice or quinoa to mix in some turmeric. And that's also going to be helping to lower inflammation and improve her estrogen levels, improve her mood, her PMS. So one thing we can also do is really help her clear out her estrogen. And here are a list of things that help women clear out their estrogen. We have DIM and I3C on the top of the list here. It doesn't mean it's my favorite supplement. It's not an order of importance basically, but DIM, so I3C needs good stomach acid to convert to DIM. So it converts to DIM in the stomach. And DIM, remember, DIM can lower circulating estrogen levels, and it tends to push the estrogen down these healthy pathways when it gets metabolized. So DIM is always an option. The broccoli sprouts, the cruciferous vegetables, the carrot family vegetables. No one talks about the carrot family vegetables, but carrots, celery, parsley, those are all great for estrogen detox. And raw unpeeled carrots are the best. They have a lot of fiber, which especially helps with phase 3 detox, just to get rid of those estrogens in the stool. Rosemary can help with phase 1 estrogen clearance. Turmeric can help lower estrogen. And of course, sulforaphane, glucoraphanin, so that's highest in broccoli sprouts. It's also high in mustard seed sprouts, cauliflower seed sprouts, but it's highest in broccoli sprouts. The sulforaphane can help with phase 2 estrogen detox, but sulforaphane also helps to protect DNA from any of those rowdy estrogen metabolites that can become reactive quinones and cause DNA damage, like the 4-OH metabolite, for example. So we also have, calcium D-glucarate, resveratrol, NAC. A lot of these, like the NAC, the magnesium, the choline, the TMG, the SAMe, and the B vitamins, a lot of those are with phase 2 estrogen detox. So they're supporting methylation. The NAC can also support sulfation. So just helping to clear out these estrogens. So with her treatment plan, with her supplements, I'm actually, I'm going to keep them how they were, how we just discussed. I'm going to add on melatonin, like 3 milligrams at bedtime, because there's been some research that due to melatonin's antioxidant properties, it can help with the egg quality and embryo implantation, which is pretty cool. So maybe with a little melatonin, it might improve her pregnancy success rate. And, I thought about adding in like an estrogen detox supplement that maybe had a combo of DIM and resveratrol and turmeric and calcium D-glucarate. But since she's motivated to work with her diet, I figure why give a supplement if they're motivated to work with their diet when you could really increase the amount of vegetables in their diet, the amount of berries. I think not only do these vegetables have the constituents that help with estrogen detox, but they're going to have a lot of other antioxidants, a lot of other constituents that are going to help with overall health and with fertility. So I try to get as much as possible from the diet. I think it's a really, really good way to approach a lot of fertility cases if they're able and willing to work with their diet. So I'm going to talk to her about adding in those brassica vegetables, the carrot family vegetables, cooking with more rosemary or taking a rosemary tincture. And broccoli sprouts. So you can do sprout subscriptions through companies like Hamama, where they'll send you the sprouts every month and you sprout them and you eat them. And it helps with your estrogen detox. Pretty cool. This is a really cool book I just wanted to mention. It's called Real Food for Pregnancy by Lily Nichols. I have the book right here. It's wonderful. I think even women who are trying to get pregnant can read this book and follow a lot of the advice, not just for pregnancy, in my opinion. All right, so here's the other things you can always add in that might help with fertility. Acupuncture, regular exercise, of course, and reducing that toxin exposure, looking at the endocrine disruptors, filtering her water. And I kind of wrote in red what I hope to achieve with these different treatment options here. So they're going to help lower her stress, help with her mood, regulate her blood sugars, help with her PMS, lower inflammation, help with sleep, hopefully help with fertility. All right, well, that was it. That's the end of our case study. I just wanted to mention that if you're a new provider to Dutch, we offer 50% off up to 5 of our kits. And existing providers, if you just tell them you saw Dr. Ruef's Facebook August presentation on infertility, you can get 50% off 2 Dutch Plus kits or 50% off 2 Dutch Complete kits. It's a pretty cool deal. If you have any questions at all, please feel free to reach out to our customer service or email sales@dutchtest.com. And that concludes our case. Thank you for listening. And of course, if you have general questions not related to sales, you can always just email us at info@dutchtest.com. All right, I hope you enjoyed that presentation. Please feel free to kind of rewind and pause and take notes. And if you have any questions, just let us know, info@dutchtest.com. All right, thanks for listening. Bye-bye.